outline would be we will talk first about impacted and unerupted teeth. We will talk about clinical examination, radiographic examination, classification, indications and contraindications, and surgical management with the complications. So, what's the difference between an impacted tooth and an unerupted tooth? An impacted tooth is a tooth that did not erupt even after its eruption time. So this tooth is supposed to erupt at 10 years of age. The tooth did not erupt. The patient's 13. So this tooth is impacted. Unerupted is the opposite. It's the general term. It includes all of the impacted and unerupted teeth. Teeth that are in the process of developing and erupting, meaning these teeth include if the patient is 7 years of age and the tooth erupts at 10, so this tooth is unerupted and not impacted. So every impacted tooth is an unerupted tooth, but not all unerupted teeth are impacted teeth. Not all unerupted are impacted, but all of the impacted teeth, they did not erupt in the oral cavity. This means they're unerupted. But if the tooth did not erupt, it doesn't mean it's impacted. It can be that its time has not come yet. Okay? Now, usually the main cause is inadequate dental arch length and space in which to erupt. So the alveolar bone is smaller than the total of the teeth. What are the more common impacted teeth? Wisdoms, maxillary and mandibular third molars, these because they are the last teeth to erupt. Maxillary canine because it's the last tooth in the sequence, meaning the lateral erupts first, the fore erupts second in the process, and then the canine. It has a long root and it has late eruption considering the adjacent teeth. Similar to the mandibular premolars, the 3 erupts first, the 6 already erupted, the 4 is present as well, the 5 usually late eruption. So mainly third molars, maxillary canines, and mandibular premolars, specifically lower 5s. Permanent teeth impaction can be due to local or systemic factors. The local are the more common ones. Now, the primary or secondary impaction causes. Primary would be like syndromes. Secondary would be arch length discrepancy. Now, systemic factors like cleidocranial dysplasia, hypothyroidism, hypopituitarism, febrile disease, Down syndrome, um, Gorlin-Gold syndrome, with cysts, of course, Gardner syndrome. We have multiple impacted teeth in these syndromes, and usually multiple teeth are involved. In the local factors, prolonged deciduous tooth retention, the primary tooth is still present for a long period of time. Malpose tooth germ due to trauma while the patient was young. Cleft lip, tumors, supernumerary teeth, arch length discrepancy, the most common one, and abnormal eruption path. Now, we need to talk a little bit about the third molars. Now, the eruption of the third molar, usually it's complete at average of 20 years. It can still erupt up to the 25 years. Up to 25 years, 30 to 50% of erupting chance is present. From up to 25, from 18 to 25, we have a 30 to 50% chance that the tooth can erupt. Now, the mandibular third molar, the germ, is visible radiographically by 9 years of old age, the cusp mineralization at 11, with the tooth being present in the anterior border of the ramus. Crown formation is usually complete by 14 years. Roots are approximately 50% formed by the age of 16 years. Now here, the body of the mandible grows in length at the expense of resorption of the anterior border of the ramus. See? Now, for mandibular third molars, that's the path of eruption. It starts in the horizontal path, then becomes mesioangular, then becomes vertical. Most of the failure of eruption due to space or whatever happens in the mesioangular to the vertical direction. That's why the most common impaction in mandibular third molars is mesioangular. Mesioangular. The most common impaction in the mandible. It's mesioangular. Okay? Now, the diagnosis is very straightforward. We inspect. Now, usually the patient will come with the complaint that the tooth did not erupt, with the pain in the mandibular, in the jaw, pain in the TMJ sometimes, so on. So the patient come with many symptoms. This will alert our reaction to look at the wisdoms. We will look at them. We will find that they did not erupt. They're not present. This means they did not erupted. We already asked the patient about the age, so this means we know if it's impacted or unerupted. Then we can ask for a panoramic X-ray. Why do we need a panoramic X-ray in such cases? Because if we have multiple impactions, if there is a pathology surrounding it, if there are some systemic factor that we need to think of after the X-ray. Now for the canine, usually it's about 10 to 13 years, different from patients, but they can erupt up to 10 to 13 years. That's when we can think it's impacted or unerupted. In the canines, we need to look at the palatal bulge. If there's a palatal bulge, this means the tooth is impacted palatally or labially, of course. So we ask the usual chief complaint, history of the chief complaint, history taking, extraoral, intraoral examination, radiographic assessment, and so on. So, clinical evaluation, we need to assess the teeth that are present in the arch. First, we suspect that there is an unimpacted tooth or an unerupted tooth. We ask about pericoronitis history. How many times did it happen? Pain, caries, periodontal disease, prosthesis, if there's any prosthesis surrounding the tooth. All of those must be accounted for before we make the clinical examination. Now, then we can go for clinic radiographic assessment. We can ask for a periapical X-ray, occlusal X-ray, panoramic X-ray, the slope technique, and the CBCT. So, this is a periapical X-ray. It's a 2D image. Now we can use two periapical X-rays to assess for the impacted canine with the slope technique, same lingual opposite buccal, meaning we're going to shift the tube of the X-ray in a mesial or distal direction. If the tooth moves with the same direction of the shift, then it's palatal or lingual. If it moves up opposite, it's buccal or labial. So same lingual, opposite buccal. Now, for the panoramic X-ray, we can use it to locate the wisdoms. We can use it to see if there are any impacted canines, if there are any lesions, any cysts, any infections surrounding the tooth, all of those. Then, occlusal X-ray can also be used to assess the impacted tooth if it's buccal or lingual. And CBCT, usually we reserve it for cases of implants or teeth that are associated with cysts and area teeth, impacted teeth that are associated with the ID canal or the ID nerve. Now, classification, there are many classifications. The angulation first, Hill and Gregory second, Winters, and the nature of the impacting tissue. Angulation, it can be mesioangular, vertical, distoangular, horizontal, buccoangular, and linguangular. Now, mesioangular is the most common, 45%. Sorry. Now, mesioangular impaction looks like this. Mesial. Horizontal, this is the third more common. The vertical is the second most common. Let's arrange it a little bit, sorry. So vertical mesioangular impaction 45%. Vertical impaction 40%. Horizontal 10%. And distoangular 6%. Now distoangular, these are the most difficult teeth to extract. Mesioangular are the easiest to extract. Distoangular are the most difficult. Okay, they're 6%. Now here is we have an X-ray. This what type of impaction do we have here? Mesioangular and this vertical. Here horizontal, vertical. So we can have different impactions in the same patient. Now, Pill and Gregory. Pill and Gregory defined on two relationships. On the relationship of the wisdom to the second molar occlusal plane and the space with the anterior border of the ramus. If the tooth is at the same level of the second molar occlusal plane, it's class A. B. Between the cement enamel junction of the second molar and the occlusal plane of the second molar. 3. Below the cervical junction. So here we have all of those are class A, those are class B. We can see they're between the teeth, and here between the root and the crown, and here we can see it's class C, deep inside. Now that's one part of the classification. The second part of the classification is class 1 to 3. 1, it's that both cusps are out of the bone. The mesiodistal diameter of the crown is anterior to the ascending grains. 2, half of the crown is covered with the bone, and 3, all of it covered with bone. Okay? Okay. So the tissue type, we can have bony impaction or soft tissue impaction. The bony can be complete or partial. For the maxillary impaction, the vertical to 63%, the most common, distoangular 25%, and mesioangular 12%, the least common. Now here's the opposite. The distoangular, it's the easiest, and the vertical. The mesioangular are the most difficult. Now, when do we go for removal or extraction of the impacted wisdoms? We go for extraction first to prevent periodontal disease. If there is a pocket between the second molar or distal to the second molar more than 5 mm, this indicates that this tooth must be extracted. Caries in the wisdom or caries in the 7 due to the wisdom. Pericoronitis. If it happens more than once a year, it needs extraction. To prevent root resorption, this is the only prophylactic indication to extract an impacted wisdom. Prophylactically, before any problems, we extract a wisdom tooth because we want to prevent the root resorption from happening. We want to prevent the 7 of being resorbed and extracting the 7 as well. Now, impacted teeth under dental prosthesis. If we have more than 2 mm of sound bone around all sides of the tooth with good soft tissue coverage, we can keep the tooth. If we don't have it, then we must extract the tooth. Okay? Sorry. An indication is less than 2 millimeter, not more. So, so if you have more than 2 millimeters of sound bone and good soft tissue coverage, we cannot extract. We can keep the teeth if we have more than 2 millimeters of sound bone and good soft tissue coverage. And if we don't have both of those, we need to extract the tooth. To prevent odontogenic cysts and tumors, now the radiolucency around the tooth defines what is the pathology. If it's 3 to 4 millimeters, we call it follicle. It's the follicle, the soft tissue that's surrounding the wisdom tooth. If it's more than 3 to 4 millimeters, then we call it a cyst, a dentigerous cyst, or pathology, let's say. Now, weirdly, some patients have pain due to unexplained origin. They have pain in the jaws, but they don't know why the pain is happening. After extraction of the wisdoms, the pain goes away. Now, it has some psychological factor to it, but it's one of the indications. To prevent jaw fractures, the presence of the wisdom teeth, it creates a higher risk of in jaw fractures, specifically angle fractures. So most of the angle fractures would happen at the area of the wisdom tooth. Now, orthodontic treatment, sometimes we need to extract them before an orthognathic surgery, around 6 to 9 months before the procedure, or during the procedure. So we either extract it during the BSSO or the Le Fort, or 6 to 9 months before the procedure. But extraction of wisdom to prevent crowding of the lower anteriors is not supported and not right. We do not extract the wisdoms due to the crowding of the lower anteriors. The crowding of the lower anteriors will happen whether the wisdoms are present or not. Okay? So here's pericoronitis. This is an infection of the soft tissue surrounding the wisdom tooth. Usually it's a partially erupted tooth. Okay? Now, do we extract immediate or no? Now, if it's an acute case, it's the only indication to give antibiotics and bring the patient back another time after 3 or 5 days when the infection has settled down. Okay? We give amoxicillin clavulanic acid, metronidazole, and analgesic. We do daily irrigation by the patient, of course, and if the patient comes to us as the acute case, we can extract the upper wisdom and do irrigation of the swelling that's present. We do irrigation to relieve the pus and the food particles. Now, it's basically because we have the soft tissue surrounding the wisdom. There's space between the wisdom and the soft tissue. So, once the patient bites, if their upper wisdom is present, this will cause food to be impacted underneath the soft tissue that's present. Regarding pericoronitis. Now, the bacteria causing pericoronitis is Fusobacterium, Actinomyces species, and Provitilla species. So the anaerobic bacteria. Now, as we talked, we said that the partially erupted wisdom tooth has a soft tissue, operculum, surrounding it. Food gets in between the tooth and the soft tissue. When the patient bites, food gets impacted, becomes pus, later on becomes food for the bacteria overgrowth, necrosis, and pus appears. Patients can present with limited mouth opening sometimes and discharge. Now, The proper management, if it's acute, we don't extract because whatever anesthesia we give, the patient will still have pain. Now, if it's associated with a limited mouth opening, dysphagia, whatever it is, we extract it under GA. But if it's not associated with dysphagia, dyspnea, whatever it is like that, only we do the extraction after antibiotic course. This is the only indication to go for antibiotic then extraction. But on the same day, we extract the upper wisdom to prevent the food impaction from happening during biting. Now, here we have an impacted canine. Should we extract it or not? If you don't see it, it's here. Now, it's controversial here because we have little amount of bone surrounding the upper part, less than 2 millimeters. So we might need to extract, but it's risky because he is an old person. So, and it's close to the inferior border of the mandible, so we need to be careful to prevent mandibular fracture. Now, here how we can see root resorption. In cases of root resorption, we do CBCT to see the amount of resorption that's present. For example, in these two teeth, we might extract the lateral and track the canine downward and then transform its shape to a lateral. In cases like what we see here, if the tooth in front seems to be unrestorable or hopeless, we extract it and keep the impacted tooth. Now, optimal periodontal healing, the two most important factors that have been shown: the extent of preoperative infrabony defect, how much the defect was before the extraction, and the age at time of surgery. Now, if the patient is under 25 years of age, even if the defect was a bit high, we have lots of bone resorption, let's say 3, 4, 5 millimeter pocket, it can come back. It can if the patient is younger than 25 years of age. If older, not really. Now, contraindications for extraction: extremes of age, patients of 70 years old, 50 years old, 60 years old, for whatever cause, we do not extract for them. If it's not indicated, of course, if the tooth does not cause any problem. Compromised medical status: the patient had an MI and 1 month ago, or less than a month ago, let's say. We don't extract. Probable excessive damage to vital structures, ID nerve, sinus. Why should we get the patient into such troubles if it's not needed? So, now if it's an emergency case, we must extract this tooth, then we do extract it. Otherwise, no. Now, here we have a tooth. I don't think it's very visible. Should we extract it or not? As we can see, the patient is probably old, in his 50s, very close to the sinus. We don't know the medical status, and not causing any problems. Why should we extract it, right? So, now let's talk about easy versus difficult extraction. When can I say, I look at an x-ray and say this tooth is difficult or easy? Now, less difficult: mesioangular impaction, class 1A Pill and Gregory, 1/3 to 2/3 root formation, soft tissue impaction, partial bony impaction, young patient, because we will have very soft bone that we can remove easily, wide periodontal ligament space, far from the second molar, far from the inferior border, inferior valvular nerve, fused conical roots. Now, fused roots are much easier to extract than long, divergent, thin roots or curved ones. Okay. The difficult: dystoangular 2 or 3, B or C Pill and Gregory, thin follicle, narrow periodontal ligament, old patient, and so on. Now the surgical procedure, we give local anesthesia, incision, reflection of the periosteum, we do guttering, sectioning of the tooth, delivery, irrigation with normal saline, wound closure, and the post-operative order. Now, local anesthesia, there will be a lecture on it, and it's the next one after the impacted teeth. So we're just going to talk a little bit here. We have mepivacaine, prilocaine, articaine, lidocaine. These are the things that are present in the local anesthetic agent. The local anesthesia, vasoconstrictor, reducing agent, preservative, isotonic solution, fungicide, vehicle, and so on. So we'll talk about it in details later. So for now, we would do local anesthesia. Let's say we're dealing with the mandibular wisdom tooth. We're going to go for ID block. While we're out, we're going to give the lingual nerve and long buccal block. For the maxillary wisdoms, we give posterior superior alveolar nerve block and greater palatine. Now the flap, which we call Ward's incision. Now, Ward's incision, simply, it is a distal extension, as we can see, more buccally angulated to prevent injury to the lingual nerve. We move around the tooth and then we make a releasing incision. We can do an envelope flap, but we need to include the 7 as well, without a releasing incision. With a releasing incision, we can end it here. The modified, we open it here if it's close to the 7. Now, my method, let's say, if the tooth is very close to the 7 and I need to see the roots of the 7, I would do the modified Ward incision. If not, the Ward incision is sufficient. Gives me good exposure and good contact. Here we can see one of the cases. Here I made the Ward's incision, distal extension, and releasing incision. And here we can see the tooth. Now what we'll do here is that we'll do what we call guttering, which is removing the bone surrounding the tooth to create space for the elevator to be placed. So that's the guttering. We remove the bone here around the tooth to make it easier to allow to put the elevator in. Now then we section the tooth if needed. I always try to put the elevator first, see if I can get mobility from the tooth. If I find it mobile, I try 1 shot, 2 shots of the elevator movement. Doesn't move, I go for sectioning. Okay. Now, there's something which we call coronectomy. Coronectomy is we remove the crown of the tooth only and leave the roots. Now here, if it's close to the ID nerve inside to prevent damage to the ID nerve. Injury to the inferior alveolar nerve is a rare but serious complication and can range from 0.5 to 8%, and 1% it's permanent. Indications include mesioangular impaction that are very close to the ID nerve or inside the ID nerve. Contraindication, horizontal impaction, mobile roots or infected roots. Now, if it's mobile, I need to remove it, and I need to tell the patient beforehand. Even if I did the coronectomy, I removed the crown and I found the roots mobile, I have to remove them. If they're mobile, I need to remove them. Here's one of the cases. As we can see, the roots are left in place and the crown removed. We remove all the enamel. All the enamel must be removed to prevent any formation of cystic masses. Now, the Rudd and Shehab's criteria. They found that we need to understand something. Some teeth are very close to the ID nerve. If we see these signs on the panoramic X-ray, we need to be careful, order a CBCT, and then we can decide if we need to extract or go for craniotomy. Now, Rod and Shihab's criteria include 7 signs, 4 to the root and 3 to the canal. Now, some of them are similar in both sides, like darkening of the root, deflection of the root, or diversion of the canal, narrowing of the root or the canal, bifid root apex, and interruption of the white line. We can't see the white line of the ID canal. Here narrowing, and here we can see diversion or changing the position of the canal. Here bifid root apex. We can see that it becomes 2 apices. We can see narrowing of the roots, deflection of the roots, darkening of the roots. These are all signs that tell us order a CBCT. Now, usually patients would be not living the normal life up to 7 days after surgery. Now we'll talk about analgesics, antibiotics, hot packs, cold packs, corticosteroids. Now, antibiotics. Prophylactic antibiotics are needed. Before the procedure, what we call is prophylactic. Therapeutic after an infection happens and we need to prescribe antibiotics for the patient. Now, it's a clean contaminated wound. The oral cavity, any wound inside of it, it's a clean contaminated. The infection rate is 5%. So if we want to prescribe antibiotic, 0.5 to 2 hours preoperatively. No need for post-op antibiotics. Maybe we can prescribe it for the first day of surgery, just getting the same dose of the prophylactic antibiotics, and that's it. Now, if we don't prescribe prophylactic antibiotics and we prescribe after that, there is no need right now. We don't need to prescribe antibiotics for patients. Okay? Unless it was infected, unless there are some systemic manifestations, fever, swelling, and so on. Now, analgesics, the post-surgical pain appears immediately after surgery, like let's say once anesthesia wears off, and at 12 hours, it's the maximum peak. Women and red-haired individuals can be more sensitive. So we give analgesics before the anesthesia wears off. So means when I extract for the patient, after 2 hours, let's say the anesthesia can wear off at 3 hours, we ask them to take a soft meal, and at 2 hours to take the medication. So once the anesthesia wears off, the analgesic can start working to prevent the maximum pain being felt. Paracetamol, non-steroidal anti-inflammatory, opioids, all of those are possible options. And the length of the operative time is very important. If we took like 1 hour to extract the tooth, we will need a lot of painkillers. But if it was like 5 minutes or 10 minutes, won't need the same, okay? Now for the first 24 hours, we use cold compressors. After 24 hours, we switch to warm compressors and moist heat to reduce muscle stiffness. Now steroids, the first dose should be given at the time of surgery. It helps in reducing the swelling post-op. Now we need to prescribe also for the second and third day post-operatively. Okay? So the maximum control of swelling 1 to 2 days following surgery becomes the worst, then it starts to go down. We can give methylprednisolone or dexamethasone. We give 4 to 12 milligrams IV at the time of surgery, 4 to 8 milligrams twice daily for the day of the surgery and 2 days afterwards. Methylprednisolone usually 125 milligrams IV at the time of surgery, followed by low doses, 40 milligrams orally, 2 times, 3 times, or 4 times daily for 2 days after the surgery. Steroids can increase the risk of alveolar osteitis, dry socket. So, postoperative complaints in summary: pain the peak 12 hours, swelling, trismus, stiffness the peak 12th day, resolves at the 5th to 7th day, and bleeding. Now, the complications include infections, tooth fracture, mandibular fractures, alveolar osteitis, and nerve disturbance. Now, for infection, the incidence is low, 1.7 to 2.7%. Mostly they are subperiosteal abscess due to lack of irrigation in the place where we put our retractor. Let's show you where the retractor is placed. Here. This is the retractor. Okay? If we don't do irrigation in this site, all the bony particles, the tooth particles, will be here, and they will cause what we call subperiosteal abscess. 4 weeks post-op, we will find that the patient has pus coming out of the area. And here we need to do irrigation, incision and drainage, and multiple things, okay? So we need to prescribe antibiotics in these cases. Now, infections in the first post-operative week, 0.5 to 1%. So it's an acceptable infection rate and would not be decreased with the administration of prophylactic antibiotics. See? But we try to prevent the infection from happening. So now, tooth fracture, the root can be displaced into the submandibular space, the ID canal, the sinus. Uninfected roots, small roots, and uninfected, we leave them in place. If we do aggressive movements, it's going to do more harm than benefit. Radiographic follow-up is only needed. Sometimes, due to uncontrolled force, we can have mandibular fractures, like in this case. Now, alveolar osteitis, it's called dry socket. It's any pain that requires the patient to return to the surgeon's office. The incidence is between 20 to 25%. It's slices of the clot that forms in the socket. Now, female smoking, oral contraceptive pills are the risk factors. Pre-surgical irrigation with chlorhexidine reduces it up to 50%, so we can have like 12% or 10% only. So it's 3 to 4 or 5 days. Might take 10 to 14 if the patient is not compliant. No need for antibiotics. Only irrigate the solution, irrigate the area, and put some local medicines. Now, nerve disturbance, 3% is the rate of ID nerve or lingual nerve injury. Now, if we have the signs that we talked about, Rod and Shihab, it can range to 8 to 22%. Now, the last part, we'll talk about impacted canines. These are the second most common teeth to be impacted, usually more palatal than labial, 2%, and mandibular 4.4%. More in females. Now, maxillary canines erupt along the lateral incisor, closing the diastema. Labial impacted canines can happen due to arch discrepancies. Palatal due to big laterals or missing laterals. There are two theories, the genetic theory or the guidance theory, and some trauma and all that. Now, if the crown of the canine is overlapping less than half of the root of the lateral incisor, there is a 91% chance that it goes back to normal. Slope technique or CBCT, we can go for exposure and traction, autotransplantation, or extraction. Now, exposure here, we open a flap This is an apically positioning flap. This is a normal flap. So we just permit natural eruption. Just expose if it's labial impaction, soft tissue impaction. But most of the time, we put what we call a bond, the orthodontic bracket. They bond it with a gold chain to track the tooth down into the arch. Okay? Now, we make a full window, full soft tissue flap. We do this procedure. Now, here we can see this is a full flap opened, the tooth exposed. We only expose the cementery enamel junction, only enough of the crown that we can place the bond on it. And then we close we close the flap. We make either window or closed underneath without any wounds or openings. Now, the apically repositioning flap usually used if less than 3 millimeters of keratinized gingiva is expected after the open window. We don't use it for high labial impactions, for thick palatal impactions. No. We treat those with the closed technique. As we can see, we put the bracket here and then we ask the orthodontist to start movement after 6 weeks once it's healed. Now, auto transplantation, we extract the bad tooth, then we extract the wisdom, for example, like in this case, we place it in the place of the 7. Then we do stitches or wires, splints to keep it in place. Six to 8 weeks after the surgical procedure, we do endodontic treatment and then conventional root canal filling at 1 year following surgery. And these are the references, and thank you. Hopefully it was good. You learned something from it, and I will start doing the local anesthesia lecture. And if you have any questions, of course, anytime, always ask. I'm always available.